MD, eBBI, European Board of Breast Imaging Professor, Professor of Radiology in University Ain Shams, Breast Imaging Consultant in Egyptian National Screening Program, former Head of Radiology Department, Breast Imaging Consultant in Armed Forces College of Medicine. Finally, I would like to thank you all for coming today and hope you will have a great day and beneficial course with our estimated, our Professor Dr. NIVINE CHALABI. Welcome, Dr. NIVINE. Let's start. Thank you so much.
Well, now I guess it's working. Okay? Okay, so just briefly, may I get to know your names, where you work, and your specialty? Doctor? Gynecology. All right.
Gynecology.
All right. Doctor? I've been introduced.
دكتور عبد الرحمن الجابي OBGY.
دكتور عبد الوكيل صالح obstetric and gynae.
Dr. Sunandini Goka, Prime Medical Center gynecologist.
Dr. Vinod Kumar.
All right. Doctor?
Anas Haj Ibrahim, General Surgery.
All right. Well, we'll have 4 sessions today, starting with a didactic lecture, then an interactive session, interactive cases. And in the interactive cases, I started by getting to know you well so that we feel no barriers between us, because actually I'll be asking you questions and you'll be answering, and no one is stigmatized or anything. So I'll start today with the mammography and tomosynthesis, which are the bread and butter of breast imaging, which means no breast radiologist would work without having mammography, revise, and now DBT as well. When I say DBT, I mean digital breast tomosynthesis. As you all may know, breast cancer is the second leading cause of cancer death in women, and the chance of a lady getting breast cancer is about 1 in 39. Is it a preventable disease? It's not. But is it a curable disease? Yes, it is, especially if early detected and small in size. The fact states that 3 out of 4 women with breast cancer have no family history of the disease, and they are not considered high risk. 1 in 6 occur in 40 to 49-year-old, and the lifetime chance of getting breast cancer is 1 in 8, which means in 1 in 8 chance she will develop breast cancer. And this also means that there are 7 in 8 chance she will never get this disease. We consider a screening test as a test that can find a disease in an asymptomatic population before it appears with symptoms and leading to an effective, less morbid treatment options. So you have a target population, which is women from 40 to 49, with a risk that is less than 15%, who have, as we said, the chances of developing breast cancer. And we need an effective screening test. What do I mean by effective? It finds cancer early, it reduces morbidity and mortality, and it has more potential benefits than harm. The development of breast cancer starts with hyperplasia within the ducts. The hyperplasia can be atypical, leading to carcinoma in situ, and then the invasive cancer. Mammography finds cancer in these very early stages. In our case, in breast cancer, mammography finds the disease in the B3 lesions and DCIS. Out of every 100 women who get a screening mammogram, 90 will be told that they're fine, they go home. Only 10 will be called back to have additional mammograms or ultrasounds. 6 of them will be reassured and sent home. And 2 of them will be asked to come after 6 months for a follow-up. only 2 will need a biopsy. This is a message that we try to deliver to the females so that they don't get scared and approach screening by mammogram easily. Why did we choose mammography? And why are we still choosing mammography after all the advances in breast imaging? Because randomized controlled trials, which are one of the most rigorous scientific studies, state that screening reduces mortality by 14 to 30%, which means it's not about finding the cancer and feeling that we have a trophy that we found cancer early. We are looking for the impact of finding this cancer on the lady's mortality. So mammography saves life, and it saves life of the women who are considered to be not only 50% of the population, but they are carrying the other 50%, whether husbands or families. And in the mammography, we have 2 distinct settings. Either screening setting, which, as I said, screens asymptomatic women, and these women should be triaged according to their lifetime risk of developing breast cancer with risk assessment tools to decide whether we will start with mammography and add a supplemental tool, or only we go for mammography and that's it. And the diagnostic settings, in which the lady is either recalled from screening, and we call this like an assessment claim. The lady has been screened, we found an abnormality, and she's been recalled. Or she's coming with a lump, and we are looking for detection and characterization. Or she is already diagnosed with a lump with a biopsy, and we are looking for staging and monitoring. Regarding the breast density, it is divided into 4 categories. Those who are almost entirely fatty, and we call them ACR category A, the ones with scattered areas of fibroglandular tissue, B, C, who are heterogeneously dense, and in that case that may obscure small masses, and the extremely dense breasts, which actually lowers the sensitivity of mammography. Simultaneously with masking the disease in mammography, the increase in the breast density leads to an increase in the risk of the lady of developing breast cancer up to 4 to 6 folds. Why did we choose, or why did the radiologist put a BI-RADS lexicon? So the communication between us as radiologists and you as clinicians becomes easy. And when I send you the report writing that the patient is she has an extremely dense breast, you need to know that my sensitivity of picking up, detecting the lesion is extremely lowered. And you understand then that when I ask for an MRI to screen the patient, it is understandable. So screening means detecting cancer early. What are we looking for to detect an answer early? Either calcifications, and for that there will be a standalone lecture entitling the calcifications, or a mass, an architectural distortion, or an asymmetry. So the mass can be, so we're looking for mass, calcification, asymmetry, architectural distortion, and other findings like skin thickening, nipple retraction, axillary lymph node, intramammary lymph node, a single solitary dilated duct, which hints that there is an abnormality within this breast. So regarding the mass, we have either round or oval, oval or round, well circumscribed as in the margin, density low, equal, or fat containing. This directs us into a benign entity. Or we can have a shape that is irregular, a margin that is indistinct, obscured, speculated, microlobulated, and a high density which takes us into a malignant possibility. The shape can be round, can be oval, just oval and well circumscribed, and we include into oval 2 or 3 undulations or lobulations. And that's why the new BI-RADS, which is the latest BI-RAD, the 5th BI-RAD, they are already working on a new one that hasn't been released yet. But the 5th edition that was in 2013 has omitted the lobular in shape. It's only oval. Then we have the round, we have the irregular ones, and then we go to the margins. The margin can be all around well circumscribed or not well circumscribed. And in the not well circumscribed margin, we have the indistinct margin, which hints towards a malignant possibility, the obscured margin, and in the obscured margin, there is a modality that helps us detect the whole margin all around, which is the DBT, or digital breast tomosynthesis, all the microlobulated margin, a not well circumscribed, again, a speculated margin, which is an overt malignant feature. And then comes the density. If it's a high density, it takes us into a malignant lesion. And in that case, the lymph nodes are specifically the ones that are very important. Sometimes we can find a round, isodense, or faint lymph node. We're not as worried as a malignant, very dense, round lymph node. One of the benign cases where there is fat containing is the hamartoma, which is a mass within a breast within the breast lesion. And the more we have fat in the density, the more we are taken into benignity, like the intramammary lymph nodes, like the hamartoma, and the fat necrosis. Other findings are nipple retraction, trabecular thickening, which occurs in cases of mastitis and inflammatory breast cancer, axillary lymph nodes, and skin lesions. Skin lesions are specifically evident in mammography by the surrounding lucent halo around, and in mammography by the location. Because in the next slides, I'm going to show you how we can decide the location by tomosynthesis of the lesion. And with tomosynthesis, we can be reassured that this is a skin lesion. What else are we looking for? Asymmetries. And the asymmetries could be global asymmetries, just asymmetries, which is a one-view asymmetry, the focal asymmetry, which is seen in two views, and the developing asymmetry, which is the most worrisome asymmetry. Global asymmetry can be, as in these cases, this case is a large malignant mass, which has locally advanced cancer, and in this case, which is just inflammatory case. The asymmetry on its own is a focal area that is not seen in the two views, only in one view. Like here, it is in the CC view, and here it is also in the CC view, and we cannot find it in the MLO. Another example of an asymmetry where I could see this as an asymmetry and that one as an asymmetry in the outer and inner breast. However, it couldn't be depicted in the MLO, and this is the tomosynthesis. There was nothing, and by ultrasound there was nothing. So that was fibroglandular tissue. However, in the same patient, I found this asymmetry, which was seen in the CC view. I could just beline here, a small thing maybe there, maybe here. But then when I took her to the ultrasound, I found this malignant speculated mass. Focal asymmetries is an asymmetry that is seen in the MLO and in the CC view. And when we have a focal asymmetry, we have to work it out till the end. I need to do a DBT, look for fat interspersing. However, if it is not concluded by compression, spot magnification, DBT, ultrasound, I need to take the patient to a higher level of diagnostic workup, which will be contrast-enhanced modality, whether a contrast-enhanced mammography or a breast MRI. The most worrisome is a developing asymmetry. And a developing asymmetry, like in this case, where this is the old ones and this is the new ones, as you can see, this asymmetry was there, but it increased in size. It resulted after biopsy into a patch. However, in that case, the asymmetry was maybe there, but not depicted. But then in the new ones, it increased in size, and upon biopsy, it revealed an invasive ductal carcinoma. So we always pay attention to any developing asymmetry, and we always pay attention to looking at the priors of the patient and making a thorough comparison. What are we looking for again? An architectural distortion. which might be, in that case, an invasive lobular carcinoma, and in that case, a radial scar. And one small hint from the experience is that when you see the center of the architectural distortion dense, this takes you into a more worrisome feature. However, in the radial scar and fat necrosis or post-operative scar, the center is usually loosened. However, it needs to be worked out with DBT, spot compression, up to biopsy and contrast studies. According to the American College of Radiology, the ACR by RADS assessment categories and management recommendation has been settled, and they should be put in your report whenever you're addressing the clinician afterwards. The first category is by RADS 0. By RADS 0 is usually in a screening setup, and the screening, the most common screening setup is the mammography. So by RADS 0 is almost solely kept for the screening mammography. If I have a diagnostic case, it's very uncommon to put by RADS 0 because you have the patient. But in the screening setting, usually, if you have a screening program, you don't have the patient. You just have the images. The patients are screened somewhere. The radiologist is sitting in a different setting, revising cases. And whenever we find a lesion, we ask to recall the patient for further assessment. And then we have the negative, which is either a normal mammogram or a benign, which is a definitely benign. So there is 0% of being malignant. Like what? Like a hamartoma, as I showed you, like a benign calcified involuted fibroadenoma, like an intramammary lymph node that is well circumscribed with a fatty center inside. In that case, we just reassure the patient and send her home back home, and we ask her to come next year for her regular screening. And then we have the probably benign, for which we ask for a 6-month follow-up, and the suspicious ones, whether A, B, or C, the highly suggestive of malignancy and a known malignancy. These categories are never used in the screening setting because in order to reach a BI-RAD 3 up to 5 or 6, I need to see the patient and do a further ultrasound, all right? Or even DBT or MRI. It finds cancer early, and this is a proof. This is a lady who came for screening, and her breast actually with ACR by RADS category B, which is good. However, upon thorough look at the mammography, we found this small mass, which is partly well circumscribed, partly obscured. So we recalled the patient to come back, and we asked for a contrast-enhanced mammography because we had this in place. And then we found a retroareolar, the same place, a small enhancing focus. What do we do next? We take the patient to the ultrasound. And it's not an easy task, especially in the fatty breast, to find such a small cancer. And it was a cancer, actually. It was biopsied and then localized with a wire. And the post-operative came back as an ADH, a focal atypical ductal hyperplasia, which according to the center, I mean, in our practice, we take it out. Because this is what I hinted about in the beginning, a B3 lesion, which is a precancerous lesion. Another case where we say it finds cancer early, and that was the case I told you it was an inflammatory case. However, in the no man's land, we found this small mass, which turned out to be a cancer. What is a no man's land? These are terminologies by our professor Laszlo Tabar, and these are areas, this is a way to find and to look for lesions. The no man's land is the Milky Way here, the parallel lines to the pectoralis major in the MLO, the retroglandular tissue, where it's only fat, we shouldn't find anything, the inner part of the breast, which should be fat with no masses inside, and then we have other areas, which is the retroareolar area, we have to look thoroughly inside. Just a hint for you that the extremely dense breast is not a good candidate for DBT. It's the worst breast you can find, either in full field digital mammography or breast DBT. And in that case, there was a cancer on the right side. However, the one we could see, and the digital tomosynthesis helps us in, was this fibroadenoma in the left side. What is DBT? It is a linear tomography, and it is the origin of a digital breast tomosynthesis is the linear tomography and computed tomography. Multiple low-dose X-ray projections are acquired in an arc. And why don't we do a CT in the breast? Because the breast is the most radiosensitive part in the human, in the female body. And breast cancer detected during a decade of screening with digital breast tomosynthesis reach a very high number and a low recall rate. So with DBT, we save the patient the worry and the government the price of bringing the patient for another investigation. And adding artificial intelligence reduce the workload in breast cancer with DBT. Again, why DBT? Because full-field digital mammography provides us with a 2D image of a 3D organ. So there is overlap of tissue, and with the overlap of tissue, we can have obscuration of an area of interest, which is clinically relevant malignancy, which results in false negative results. Or it creates a pseudo lesion, which we call a summation artifact, and this increases the false positive results. So with the DBT, which we call a 3D mammography, I'll give you an example of a 48-year-old woman, which was a false negative. She had a dense breast, and in the regular mammography, there was nothing. However, in the DBT, there was this architectural distortion, which upon biopsy revealed an intermediate grade invasive ductal carcinoma. So it helps in supplementary screening in dense breast, increasing the rates of cancer detection, decreasing the recall rate, and increasing sensitivity and specificity in dense breast. So one first indication is dense breast. And in diagnostic setting, it helps me in characterizing benign from malignant lesions through the margin delineation, the tumor size, extent, multicentricity, multifocality, and the architectural distortions and asymmetries. How is DBT done? Multiple low-dose X-ray images are acquired in an arc. Spot compression can be done. We can obtain implant-displaced views. However, DBT cannot be performed with magnification views, and DBT is a bit weak in calcifications. This is the resulting images. And in the calcification, to avoid the false negative ones, there is a technique called step and shoot, which means we have two techniques. Either the X-ray tube moves continuously in an arc that depends from different manufacturers, from 15 to 25, or it stops and shoots, and stops and shoots, moves, stop and shoot, which helps, which is a way in helping in seeing the calcifications in DBT. Most of the new machines are really good with calcifications in DBT. Another problem with calcification is that the tomosynthesis shows the lesion in focus. And when you go out of focus, the lesion blurs. Like in that case where we put a tissue marker in a lymph node, you can see it well only when the lesion is in focus with the DBT and with the X-ray tube. This was actually a lymph node with extra capsular invasion, and a clip marker was put inside. So how come we do DBT and we have also a mammogram in the same image? With the synthetic mammography. And the synthetic mammography consists of a 2D image reconstructed from the volume we took from the digital DBT data. The strengths include an increased conspicuity of calcification, increased definition of speculated margin, and better visualization of architectural distortions. The artifacts may be subcutaneous tissue blurring, skin resolution loss, axillary resolution loss on MLO view, and sometimes pseudo-calcifications. The imaging protocol can go from either tomosynthesis with a synthetic 2D, and this one has a very nice advantage is that it creates the synthesized 2D image from the DBT dataset, and that's how we get a lower radiation dose. This technology has been shown to perform comparably to combination imaging, and this is what we do in our practice, in my practice personally in Egypt. Another way, which is the combo mode, an acquisition mode which takes a full field digital mammography, and then a DBT is done in the same setting, but it has a higher radiation exposure. So in our practice, we do the DBT and synthetic 2D images, and this is what you're seeing here is CC and MLO synthetic view. I don't think you can see a difference from this from full field digital mammography. And then we have in the workstation the 2D synthetic image, the MLO, the CC, and then we have the slab DBT and the plane DBT. And the difference between the slab and the plane is the thickness of the section that we take within the breast. On the side, we have this index, which helps you either move in a cine loop. Rabbit means you're moving fast, turtle means you're moving slow. And you have this diagram which tells you this is an MLO view, so I have upper and lower. However, in this diagram, it helps me see whether I am in the inner or the outer breast. And that's why it helps me localize the lesion from one view. This is a 50-year-old female with a left palpable finding. And as you can see in the full field digital mammography, there is maybe a mass with speculation here, maybe a density here. And actually, what took our attention was this density that we considered a focal asymmetry. But then we did the DBT and we found actually this speculated mass and that small one, and they were confirmed by ultrasound and biopsy to return as multifocal invasive ductal carcinoma. How about the focal asymmetry? This is actually the same case I'm talking about. And thanks to the DBT, we could delineate that this is summated artifact. This is condensed fibroglandular tissue. As you can see, there is fat interspersed inside. And it was totally fine in the MLO view. Regarding the masses or the densities, in that case, that was an obscured mass that by DBT showed a speculated mass that upon biopsy revealed an invasive lobular carcinoma. So the indications are the assessment of non-calcified cancer, architectural distortion with a very high positive predictive value reaching 60%, focal asymmetries, and masses. The improved visualization of architectural distortion appears as in this case, where the distortion is best seen in the tomosynthesis, and this revealed an invasive ductal carcinoma. This is a case that came after a conservative breast surgery, and upon mammography there was this density. I was not feeling comfortable calling it an architectural distortion just caused by the scar in the operative bed. And while doing the tomosynthesis, I found the speculation, and I found the center to be iso or hypodense. However, in ultrasound, this showed a very ugly, nasty mass, which proved to be a recurrence. This is a DBT for another case, which shows the multifocality. And it was a multifocal invasive ductal carcinoma with calcifications. This is the ultrasound of the index lesion. This is the ultrasound of the small satellite. How about focal asymmetry? Focal asymmetry is an asymmetry that is seen in two views. And in that case, DBT was done, and it was localized and revealed an invasive ductal carcinoma. Again, regarding the mass shape, the speculations appear better with DBT. Here is this case where the extent of the tumor of the speculation was seen in digital tomosynthesis. And the margin of the mass was better delineated by DBT. This is a plain DBT. As you can see, the images are going very slowly because they are very small in thickness. And this is a slab. As you can see the difference, this one goes very quick because the reconstruction has been made in a thicker slice thickness. The tumor size is best seen in MRI, which has the highest correlation to the pathological size, then by tomosynthesis, and lastly by ultrasound and mammography. The number of tumors and satellites can be well delineated with the DBT. As you can see in this full field digital mammography, it's only one lesion that has been depicted. However, here there are 3 lesions that were consequently seen by ultrasound, and that was a multifocal disease as well. Again, for the staging of multifocality and multicentricity, as you can see, this plain DBT, there are 1, 2, and a suspicious 3rd lesion in that case. So 1, 2, and a 3rd case, and a 3rd malignancy. And this is the ultrasound of the case, the ultrasound of the satellite, another one. So the important points are that cancer can engulf surrounding adipose tissue. As you saw in the recurrence in the operative bed scar, it had hypolucency inside, but it turned out to be a recurrence. So it's better seen in DBT given the thin sections used. Masses at DBT should be evaluated according to their shape and margin rather than their fat content. The presence of fat should not deter biopsy if the shape and margins are suspicious. As in this case, that turned out to be an invasive lobular carcinoma. And if cancer is visible in only one view, which we call an asymmetry, it is more likely to be visible in the CC view than the MLO. And this is where we put more attention and take the patient to a further diagnostic setup. If diagnostic DBT, it's important to find the lesion on 2 views for complete assessment and to target ultrasound in the correct location. And in that case, maybe we don't have enough time to discuss this. Either we find the location via the ruler or the thing that is put on the side of the tomosynthesis, or else we go back to the old triangulation method by taking a CC view, a dead lateral view, and an MLO view, and see how the lesion moves, whether up or down, to detect the exact location and try to find it in ultrasound, to go for an ultrasound-guided biopsy. Skin markers are not so good in DBT. They create an imaging artifact, and masses are of usually lower density in DBT. The potential limitations is the patient breast size. It's sometimes difficult to obtain a single DBT in each projection by positioning the area of interest or areas with dense parenchymal tissue within. The extremely dense tissue, like I showed you in the ACRD, there are potential false negatives. And this is an important point because in ACRD, DBT is not the last line in our book. We have to go for a contrast mammography or a contrast study, and the calcifications, either a step and shoot, or we take the slab viewing to show the calcification better. Regarding the irradiation, well, using reconstructed full field, which is the sensitized 2D image, is estimated to reduce the radiation dose by around 40 to 50%. And the cost and availability of DBT, of course. Finally, DBT only findings. The biopsy is a concern, or used to be a concern, because now it is available and it is commercially available, except that it is very expensive to install everywhere. This is an example of a false negative finding related to the technique resulting from an ACRD. the cancer was in there and it didn't show. So the take-home messages is that women should not die from breast cancer. More than 95% of women diagnosed with early stage breast cancer, they survive and they thrive. Thank you very much. Now we will go to the interactive session. There is hour. That's fine? Can you hear me well? All right. So let's proceed. My intended learning objectives is that most of the processes that result in calcium deposition are benign, so stay reassured. A systematic method to detect and analyze breast calcification is very important using the BI-RADS terms. And the BI-RADS term and positive predictive value for calcification shapes and distribution is very high, which is I'm going to highlight. And I will highlight the don't touch calcifications. And what are the BI-RAD3 calcifications according to the 2013 BI-RADS Atlas? So as I was just saying, we need to detect the calcifications, then analyze, categorize, and then act upon. To detect, we have to have a systematic search for the calcifications. And the best one who described this is Professor Laszlo Tabar. We have to put the mammogram side by side. We have to take each part, the upper, the middle, the lower, and pay very special attention to the hidden areas, the no man's land, the areas where there shouldn't be any masses or calcifications. The spot magnification using a 0.1 focal spot is a technique that visualizes the calcification better than the photographically magnified view. So if you have a trained technologist, it's always nice to tell her, if you find calcification, go on for a spot mag on the spot. Okay, we now need to analyze the calcification. We need to locate the calcification within the breast. Is it in which quadrant, retroareolar, etc., and then start describing them according to the descriptors, to the BI-RADS lexicon, and then compare with the previous studies, which is very important. And bear in mind, this is the most important thing in BI-RAD3 calcifications. Okay, we have seen them, we have analyzed them, we need to categorize either into typically benign, and these are categorized as BI-RAD2. We don't touch them and we leave them alone. Or they are of intermediate concern, what we call BI-RAD3, categorized as BI-RAD3. And in that case, we put a surveillance algorithm. And this is the new thing, because in the old BI-RADS, category 3 was there. There was a whole intermediate concern that has been removed, and only specific calcifications are kept here in this category, or suspicious ones assigned by BI-RAD4, and we have to go for an action plan. What is the action that we have to do? Either take an image-guided biopsy. An image-guided biopsy, remember please to take the patient to the ultrasound, because this is the easiest, most-effective method to guide us to biopsy. Or we have to resort to a stereotactic biopsy, in that case, whether prone or upright. Which biopsy system are we going to use? A vacuum, a blast? Are we going to insert a clip? The image cores, are we going to image them and then put them into two separate tubes for the pathologist? This is the tube with calcification, this is the tube without calcification. Or are we going to put a wire and go for excision biopsy and do a post-specimen radiograph? So in that case, she was a lady coming for a diagnostic mammogram because she had a palpable lump and there was this nasty segmental pleomorphic calcification, and I could find them in ultrasound. So I just took a biopsy by ultrasound, and it came back as a malignant invasive ductal carcinoma, and it was positive for metastasis. And then after the biopsy and the result, I did an MRI to know the extent of the DCIS. And actually it was extensive, and that patient had to go for a mastectomy. Or a stereotactic biopsy, because if I cannot find the calcification, I would go for a stereo biopsy, whether upright or the prone. And I would advise, whenever you have the option to use a vacuum in a stereotactic biopsy, please go for it. The core biopsy using the core biopsy system in the stereo biopsy, especially in the calcification, is really hazardous because we might miss the lesions. We have 14 gauge and we might have 12 gauge. However, if you use a vacuum, you have a 9 or 8 gauge bore and you get really a good amount. You might take all the calcifications away. The second thing is to choose the approach, as in this case. This is, especially if you have a vertical approach. I don't know if you're working stereotactic biopsies here, but if you have a vertical approach for the needle, you need to detect in which direction you're going to go. I mean, this direction to the calcification is a long distance if you go from the superior skin surface. However, if you go here from the lateral skin surface, it's a smaller distance to reach the calcifications. Okay, we have acted, we have taken a vacuum, a stereotactic guided biopsy, and then we image the biopsy, we image the pores. This has calcification, this has calcification, this one, that one, that one. We put them in two different tubes because the pathologists don't go thoroughly through all the cores usually. So when you divide them for the pathologist, you're making his job easier to make sure that the calcifications have been taken out. As a rule of thumb, we should insert a clip in each lesion we biopsy. But because of the cost, we reserve this for special conditions, as in the calcifications, because sometimes we might remove the whole part of the calcifications and there are no calcifications here, and next time we will put a wire in this clip for excision treatment. The rad path concordance is very important, and this is discussed not usually in an MDT. Sometimes there is a very concise meeting between the radiologist and the pathologist to discuss the discordant. I mean, like I was just saying, I put a lesion, a BI-RADS 5, and then it comes back as a B2 lesion. This is not acceptable. So we discuss where is the problem. Is it that the cores were not enough, or the reading was a problem or something? So communication with the attendant physician is very important, as well as the pathologist. The other option, if we don't have a stereotactic guided biopsy system, we might have a stereotactic guided wire localization, and this is what we used to do before having the stereo biopsy, that we insert a guide wire, and then the surgeon goes, follows the wire, remove the calcification, takes a specimen radiograph, and when we do that, we need to show, I mean, like draw for the surgeon. This is the clip, this is the wire. Well, I've been moving like 1 centimeter beyond the clip. This description is very beneficial for the surgeon. This is the specimen radiograph that confirms that all the calcifications were removed. Preferably, if I can see the wire as well, it's very beneficial. Would we recommend a contrast study? I do recommend a contrast study because I do believe, not only it's a belief, it's supported by the literature, that as long as there is a blood vessel going to the duct that contains the DCIS, then DCIS should enhance in MRI or contrast enhanced mammography. And let me tell you that the literature confirms that the high-grade non-calcifying DCIS are best seen by MRI. They are not seen by mammography. And the low-grade DCIS, which is calcifying, is the one that we depict in mammogram. So the DCIS extent is very important to be delineated to the surgeon in contrast mammography or MRI, and I can discuss it later on with you, which one is better according to the localization guidance that you have. If you have an MR guided localization method or biopsy method, then go for the MRI. This is an example where the calcification were regional, extensive. They took all this part. However, the MRI shows a smaller part with an invasive lesion. In this case, the calcification was only this small part. This area was affected by DCIS by the MRI. So in that case, MRI was better as out there individual shape. However, the contrast study shows an extensive disease that required mastectomy for the patient. Calcification location correlation through BI-RAD terminology, which is where do the calcification come from, so that we can decide whether they're benign or not and their shape. The round calcification and the milk of calcium, they come from the acini and the ducts. However, the fine linear branching calcification, which is the most suspicious, they come from the TDLU, which is the terminal ductal lobular unit, epithelium, and they extend into the ducts. Finally, the large benign rod-like calcification, they are secretory, and they can occur inside the duct or outside the ducts in, that we used to call plasma cell mastitis. In the calcification report, the first thing we have to comment upon is the size of the calcific group, though it is debatable. However, the number of equal or more than 5 in a cubic centimeter is considered suspicious. Can we biopsy a cluster containing fewer than 5 calcifications? Yes, we can. If the individual calcification is extremely suspicious or within a suspicious clinical scenario, a diagnostic patient with a palpable stellate or speculated mass. Or if magnification shows many more tiny calcification than the ones showed in the regular mammogram. The second thing, we talked about the size. The location is very important, right or left, the quadrant, etc. The calcification descriptors. And the calcification descriptors, we give the patient always the benefit of the doubt. So we consider the most suspicious and we generalize upon it. Let's take it bit by bit. The typically benign calcifications are the skin with rim appearance, the lucent center calcifications. These are the skin calcifications. We just leave them alone and we don't touch them. Another typically benign is the vascular calcification. I advise you not to fear writing in your report, this is a typically benign calcification, because the patient might not come back to you. So you are sending a message to your colleague radiologist, you leave these alone. These are the vascular calcifications, which sometimes they might be misleading, because when they are just starting at the beginning, they might appear as linear calcification, but you find, you correlate with the patient age, you correlate with the other side. Mind you, you don't get satisfied with your search whenever you find vascular calcification, because this is a group of amorphous calcification that turned out to be atypical ductal hyperplasia. Again, this is pathologically a B3 lesion that might predispose to DCIS and cancer. Another typically benign, the popcorn calcification. We heard that they are going to remove popcorn from the new atlas. However, we like to call it popcorn because it is pathognomonic for an involuting fibroadenoma that we are confidently categorizing as BIRAT2. And a very important thing is that sometimes you get these young ladies who have calcified fibroadenomas. They are young, so we're not doing a mammogram, and you find extreme shadowing in the ultrasound. So when you have very strong shadowing in ultrasound, try to manipulate your probe or even take a mammographic picture to make sure that this is not a calcified fibroadenoma, because I encountered this case. This case was referred to me after she had all this story. She was sent, she had a mammogram elsewhere, and the mammogram said that there is a left breast mass BIRAT5 without doing, no, they did the mammogram. I don't know how they called this lesion. They didn't correlate probably the mammographic calcification, which is in a very old film here. They didn't correlate this one with the thing they saw in the ultrasound. So the patient had to go to the theater, okay, and endure general anesthesia to come back with a fibroadenoma with hyalinosis and calcification. That's why there are two things that we always teach our residents: beware of a hard calcifying mass in the ultrasound or a cyst that you can see in the axilla, because the cyst is maybe a pathological rounded lymph node. Okay, these are different stages, and as you can see here, the calcification started as coarse heterogeneous, that might be suspicious, and then it gradually increased, and these are different stages of calcifying fibroadenomas. The typically benign ones, thank you. The typically benign ones that we said are rod-like, that we used to call plasma cell mastitis or secretory disease. They can be intraductal, and you can see they are large rod ones, or periductal, and these are the ones where you can see lucent center inside. Again, typically benign. Mind you, the satisfaction of search, there is a group of fine pleomorphic calcifications here that turned out to be DCIS. The typically benign, again, are the round and punctate. And the difference between round and punctate is the size. The punctate is 0.5 millimeters, and the round ones are more than 5%. And you can confidently call them typically benign, especially if they are diffuse. These are the ones that are made in the SNI. Typically benign, punctate, increasing over time with comparison. This is fibrocystic disease. And another ones that are increasing and benign as well, as you can see in C. The typically benign, the rim calcification, varying degree of calcification occurs, and the most famous one is the oil cyst. A calcification which occurs, as in this one, in necrosing fat necrosis. Okay, another type is rim. We used to call them, I think, eggshell, but now we don't call them eggshell. They are rim calcifying. And this lady had a palpable lump, and there is an architectural distortion here of an old scar. And this is a skin mark that we put. We don't have the skin mark in our in my institute, so we use the stapler. We take a stapler and we take one staple, and then we put it on the skin, and we take another mammogram if we have something on the ultrasound, or we just put it to make sure that the palpable lesion where the lady is complaining corresponds to this benign calcification. Are you in doubt? Well, okay, if you're in doubt, you go for an MRI, and the MRI, there is a pathognomonic sequence which is called the T1 weighted image, where you can find the central fatty part with no suppression. This is a fat necrosis. If you're in doubt, again, you can do a biopsy. The dystrophic calcification, which occur in the surgical beds of both benign and malignant disease with areas of trauma, sheet-like calcification with radiolucent center, and common in lumpectomy beds after radiation therapy. This is the plane of dissection in a surgical scar, and you can see here the metallic clips to be reassured that this is an operative bed scar. Again, history and architectural distortion, and history is very important, that the patient had a trauma in this area or she had a surgical procedure. Again, you can put the skin mark. What are the milk of calcium? The milk of calcium are those calcifications that occur within fibrocystic, when the lobules, when the acini, they start to dilate, preceding a fibrocystic change, and then you have the calcium just layering in the acini, in the dilated acini, and you find them in the craniocaudal position as is, and then they start to laying as the teacup in the MLO. When the calcifications are plainly seen in the lateral or MLO, but are hard to see in, or just a vague smudge in the CC views, you know this is a milk of calcium. And just a hint of advice in that case, when you suspect this and you are deciding to take like a dead lateral to make sure that it's going to layer down, you ask the technologist to wait for like 1 minute so that you give time for the calcification to sediment in the base of the acini, to have these lines of milk of calcium. All right? Again, these are typically benign. I was just saying this hint that you need to give the patient some time for the calcification to layer. Again, the satisfaction of surge. You have, yes, milk of calcium here, but you have a group of calcification that is suspicious and that needs further workup, and it turned out to be a DCIS. Typically benign, yes, the ones that associate sutures or loops and knots. These are calcifications that are typically benign, and the way to decide this is knowing the history of the patient. That's why the clinical history is extremely important. Calcified sutures, they increase with time. I mean, you can see that it has increased in time. This might be suspicious, especially that it's linear. If you know the history of the patient and you look at the architectural distortion and you look at the priors, you can decide that these are benign calcification. Now, a very, very distinct calcification group that is only characterized or categorized as BI-RAD3, because in the BI-RADS atlas, we have only 3 entities that are called BI-RAD3. A solitary grouped punctate calcification that is non-palpable, stable, seen for the first time, and have been evaluated with magnification mammography. This is the only case where you can categorize it as BI-RAD3. Otherwise, if they are new, palpable, increasing, pleomorphic, and do not fulfill the criteria, they should be biopsied. So we have in the atlas a surveillance algorithm. which should be followed if they are non-palpable, first seen, etc. First thing is that we do a 6-month interval mammogram for the side that is affected. Say the lady is coming now in 2024 and she has a mammogram that has been done, and we have this category 3 calcification in the left breast. So I'm going to do another mammogram in 6 months to the left breast and compare. If the lesion is stable and no new findings, I will consider this again BI-RAD 3. So I will do a 12-month initial, another 6-month follow-up mammogram, which is 12 months from the initial one. If the lesion is stable, then 12 months from the recent one. So I have 6 months, 6 months, 12 months. And now I will have lesion stability, and I will go for the annual mammogram. All right? So this is the only category that can be considered by RAD. Let's go for the suspicious morphology. And the percentage you're seeing here is the positive predictive value for these cases, for these calcifications to be malignant. We have the amorphous, the coarse heterogeneous, the fine pleomorphic, the fine linear, and the fine linear branches, and the likelihood of malignancy increases as you are going to the right-hand side. So the suspicious is the amorphous, coarse heterogeneous, fine linear, and fine linear branching. The coarse heterogeneous, they are irregular in shape, that is regarding the individual shape, between 0.5 and 1 millimeter in size, denser and more conspicuous than the amorphous ones, and they tend to merge into each other. They form inside the pockets of necrotic tumor, hence the form of the calcifications, such as the micropapillary and the cribriform forms of DCIS. They might be seen early calcifying fibroadenoma or dystrophic calcification, especially if bilateral and grouped. An isolated cluster has a PPV of 13% for cancer, should be biopsied if not in a fibroadenoma. So the solution is to do an ultrasound if it is a fibroadenoma, so we are reassured and we don't need to biopsy. Coarse heterogeneous examples where the final diagnosis is benign, like in this case, it was in a fibroadenoma, and in that case, it was fibrosis. However, the individual shape of the calcification is suspicious. Another case of fibroadenoma and fat necrosis. Coarse heterogeneous, but the result came back malignant, like this is a ductal carcinoma in situ, this is an invasive ductal carcinoma, and this is an IDC, and I do not think by any means that anyone would disregard these as suspicious of malignancy. Another coarse heterogeneous where the final diagnosis was malignant as the CIS, and now comes the amorphous. And personally, I hate the amorphous calcifications. It's exactly like this guy is showing. I have to put a lot of effort and I have to ask myself, is this a group of calcification or not? And I put invert on the workstation. They are indistinct, they are hazy and roundish and actually difficult to biopsy. However, they have a positive predictive value of 21%. So the more you look, the more you find. This is a group of amorphous calcification that turned out to be here a benign sclerotic tissue and here proliferative fibrocystic disease. Another example that came back as flat epithelial atypia, atypical ductal hyperplasia, which we call the B3 lesion or the precancerous lesions. Amorphous, where the final diagnosis again was flat epithelial atypia with microcalcification that was not upgraded into DCIS in surgery. Here there is the DCIS, amorphous calcification, invasive ductal carcinoma and ADH, and this is a focus of DCIS. Amorphous calcification in a segmental distribution is suspicious. Okay, extremely suspicious. And the stereotactic biopsy came back as micropapillary DCIS spanning over 6 centimeters, which is an extensive DCIS. And I would assume, without even seeing, that if this patient had done an MRI or a contrast enhanced mammography, that maybe even the extent of enhancement would be much more. Fine pleomorphic. And fine pleomorphic, as more as we go into fine pleomorphic and fine linear, we are increasing the PPV towards malignancy. And these are tiny, they are smaller than 0.5 to differentiate them from the coarse heterogeneous. They are discrete, individual, irregular shape. Pleo means multiple and morphic means morphology. So they are individual, irregular shapes of different shapes. And as we said regarding the size. This is an example in benign ducts, in sclerosing adenosis. Should we biopsy this? Yes, we should biopsy this based on the individual calcification morphology. And as you can see, each one of the calcification has a different shape than the other. Fine pleomorphic here and amorphous in a fine linear distribution. It is a DCIS, another group DCIS, and here as well, despite they are very small, as we were saying, if you find them less than 5 in a cubic centimeter, but they are suspicious, you need to go for a stereo biopsy. That's the typical image of suspicious calcification, as in the distribution and the individual shape. And this is the fine pleomorphic. Now we go to the highest PPV, which is 70%, the fine linear and fine linear branching calcification. Whenever you find these calcification, you should go for a biopsy, be it contrast mammography free, be it be it MRI free. You have to do a biopsy because they form within the ducts and it makes them irregular casts, what Laszlo Tabar in his atlas calls the casting calcification, as if you have a broken limb and you're putting a cast. These are the casting calcification that are the most suspicious ones. And a hint of the ductal carcinoma in situ, the histological architecture includes the comedocarcinoma, which is the worst carcinoma of the worst DCIS, and then we have the micropapillary, the solid, and the cribriform, and the calcification they form according to these pathologies. So you have these calcification, which are the fine linear and linear branching. They come with the comedo because they form here inside this tube that is filled with malignant masses. Again, this is a case of fine linear and linear branching calcification in a linear distribution that came back as DCIS comedocarcinoma. Typical, again, of a comedocarcinoma. As you can see, they are filling the ducts and they come as linear and linear branching, as in this picture. The cribriform, they appear as fine pleomorphic because yes, it's true that the duct is filled with malignant masses, the violet ones, and the spaces that fill with calcium are irregular and different shapes, which brings the pleomorphic calcifications, as in DCIS. This is a single calcification. I wouldn't actually, this is from the literature, but it's a small that is called by secretion within the duct. Okay. A group of amorphous and pactate calcification, they form in the cribriform, where you have multiple small spaces that are filled with calcium. They come back here as amorphous calcification. So the morphology, the classic appearance of DCIS calcification is the fine linear or the fine linear branching. I could not highlight more than this, that these are the most suspicious. They are never left alone. They have to be biopsy. Now comes the distribution of the calcification. They can be diffuse, what we used to call in the old BIRADS atlas as scattered, or regional, where they take more than a quadrant group, which is a small focus. Linear, they follow the duct, and the segmental. The highest PPV goes for the grouped, linear, and the highest one is the segmental calcification, up to 62%. These are typically benign, leave them alone. These ones are regional because they take a large area, more than a quadrant. However, the individual shape of the calcification are benign. So these are benign calcifications. Another distribution, regional distribution. Okay, regional distribution, we can accept that, but we cannot accept this coarse heterogeneous and pleomorphic and fine linear and linear branching individual distribution. And these came back as DCIS. Especially that they are distributed in a segmental pattern and here in a regional distribution. Grouped ones, these are the ones that we used to say if they are less than 2 centimeters, we consider them grouped, and we decide upon the individual shape and whether the spot mag shows me more calcifications or not. These are benign ducts. However, this is suspicious because they are fine pleomorphic and they are more than 2 centimeters. Amorphous ones in DCIS. And the lower limit of use of this descriptor, which is linear distribution, is when you have five calcification groups within 1 centimeter from another, or where there is a definable pattern there. And the upper limit of use for this descriptor, where larger numbers are grouped within 2 centimeters from each other. Typically benign morphology in a suspicious distribution is suspicious. So these are typically benign. These are rounded and punctate calcification. However, they are distributed in a linear distribution and they came back as DCIS. So again, the linear distribution has a positive predictive value of 60%, whether amorphous, or fine linear, but they are in a linear distribution, we have to biopsy these. The segmental distribution, it has the highest positive predictive value for suspicion of malignancy. Here is an example of triangle. Actually, segmental means there is it's distributed in a triangle that points towards the nipple. Another example here, it came back as ADH, and this one came back as DCIS. As you can see here, these are the additional findings that we can find with calcification. If we find calcification, we have to look if they are benign. We don't get satisfied with our search. We look for other groups of calcification, or we look for other findings within the mammogram, like in this case, this dense axillary lymph node. The associated findings like axillary lymph node, like thickened skin, like trabecular thickening, etc., and the change from the previous films. In calcification, it is a mandate to compare with the priors. I sometimes withhold the report from the lady, and I ask her to come next time with her priors, so I can decide whether I'm going to put her as BIRAD 3 and subdue her to another mammogram or in 6 months, or just send her home for her annual mammogram. Stable suspicious calcification. By the way, suspicious calcification can be stable from 5 to 50 months, yet they will still cancer when they were finally biopsied. Suspicious calcification, they are usually associated with invasive cancer if they increase in number, and they should be biopsied even if on prior mammograms and even if they are stable. So as flashcards, a single group of coarse heterogeneous calcification has a PPV of 13%, slightly less than 15%. BIRAD's category assessment is 4B. Another fine pleomorphic calcification with a PPV of around 30%, BIRAD's category 4B, suspicious, should undergo biopsy. Fine linear and fine linear branching calcification, they have the highest PPV. So their category is 4B. They should be biopsied regardless of their distribution. So my take-home message to solve this dilemma is to use a hand-on optical magnifier to see calcification on standard mammograms, and an air gap magnification used to work up calcifications. Both the individual form and the distribution are clues to finding cancer. Decision to biopsy is based on the worst feature. As I just said, we give the patient the benefit of the doubt. BIRAD 3 is assigned to a very, very special case according to the BIRAD's 5th edition. Calcification are not a feature of invasive lobular carcinoma and are rarely a feature of lobular carcinoma in situ. Fine pleomorphic or fine linear or linear branching have the highest PPV in morphology. They may represent DCIS or invasive ductal cancer. Thank you very much for your attention. Will you make it on time? Will you be able to okay, for the prayer?
Thank you, Dr. Nivine, and we will go for a break. We will be back at 1:30 after the prayer time. Thanks a lot.
12:30?
1:30.
1:30,
Yeah.
okay.
Okay.
Right. Great. Good afternoon, everybody. So we're back.
Yeah, good afternoon, everyone. Sorry, Doctor. We are going to start the second session. Thank you, Dr. Nivine, and sorry for being a little bit late, but we will continue it normally. Thank you so much. I hope you will enjoy the rest of the day.
Okay, I'll try to stick by the time. So now we're going to talk about contrast-enhanced mammography, adding the power of contrast medium to the credibility of the mammography. A few days ago, a friend of mine who's not a doctor sent me a TikTok with this nice resident. And telling me there are updates in mammography and breast cancer treatment and diagnosis. And actually the most important thing for me was that 3D tomosynthesis and contrast approvals for mammogram to hopefully catch cancer sooner, but also to decrease false scares, which is something we are proud to have in radiology. So what is contrast-enhanced mammography? It is going, in the imaging advances at the first session, we went from 2D mammography to 3D mammography. Now we are going from the sole morphological information into functional behavior. The structural information, we get it from full-field digital mammography, digital breast tomosynthesis, handheld ultrasound, plus or minus elastography, automated breast ultrasound, or eBBI. But then if we add contrast media, we have functional information of the tumor neovascularity. And this is via the contrast-enhanced mammography. And you will find me saying contrast-enhanced spectral mammography sometimes, or CISM, or contrast-enhanced mammography. This is because the spectral mammography, they changed it into SIM so that there is no bias for any of the manufacturers. Or the dynamic contrast-enhanced MRI, the contrast-enhanced ultrasound, and the PEM, which is the positron emission mammography. What's the concept? The concept is the same, whether in contrast-enhanced mammography or MRI, that the new vessels that form in the cancer are very weak, they have pores, and they leak the contrast outside, hence we get enhancement. There are two approaches for contrast-enhanced mammography. Either the temporal approach, where we take images before the contrast injection and after the contrast injection, we do a subtraction, kind of similar to the MRI, and hence we get kinetic data about the tumor, or the spectral or the dual energy approach, where we take a pair, two images, but only after the contrast enhancement. The two images are after injection, and then algorithmically they are treated, and we have a subtracted image where we take off the fibroglandular tissue and we have the enhancement, but we don't have any kinetic data. The basics of dual energy contrast enhanced mammography technique is that 2 minutes, we put a cannula, and then we better have an injector, and then after we do the injection, which is 1.5 milliliters per kg body weight, 2 minutes after that, we start after the injection of an iodinated contrast media, and it's important to be iodinated. I'll tell you in a second why. We take 2 CC images, 2 craniocaudal and 2 MLOs of each breast. They are obtained, and then we have the first image, which is a high energy, which is higher than the kV of the iodine. It is a non-diagnostic, non-interpretable image. And a second one, which is the low energy, which is an imitation or just similar to the regular mammogram, and it is considered the diagnostic equivalent of standard full-field digital mammography. After image acquisition, a post-processed dual energy subtraction technique is applied, and then we have a subtracted or recombined diagnostic image, which highlights only the areas of contrast material uptake, removing the non-enhanced fibroglandular tissue. To minimize the motion artifact, they are best obtained sequentially for each breast position. However, in the protocol, I'll tell you that it's different from center to center and from institution to the other. And the standard imaging, you have up to 10 minutes, but actually it takes like 4 to 5 minutes to do it. Additional views can be obtained at upward to 10 minutes. Sometimes we take a delayed image, so we can have a kind of kinetic information about the tumor. So this is the raw or the high energy, which is non-diagnostic. We don't even see it. And this is the low energy, which is similar to a regular mammogram. And this is the recombined image after the subtraction of the fibroglandular tissue. And if there is an enhancement, if there is a contrast uptake, you will see it in this image. This is an example of a lady who came with a right palpable mass. As you can see here, there is a speculated mass. Something is not working here. And after doing mammogram, we found that the other side shows segmental pleomorphic suspicious calcification. So we opted for a contrast mammography. And what's very nice about the contrast mammography is that you can toggle between the low energy and the recombined image, as you can see. So you can see the low energy, and then you see that the calcifications are enhancing. Actually, this lady, we took a biopsy from the lesions, those lesions, and it came back as invasive carcinoma. So we simply scroll between the low energy and the high energy, and the, recombined image, and you can depict the enhancing areas. How about the dose? As I was just saying, it's 1.5 per kg, and I insist that the nurse weighs the lady when she comes, but we have a maximum of 120 mils of contrast in any patient that exceeds the weight. Creatinine levels must be performed on every 170 and over. We do it regularly on every patient without concern to the age. The EFR guidelines, the guidelines say that the glomerular filtration rate 45 and over is okay. However, under 30, we do not inject contrast. And we prefer this because, as you know, the serum creat may be modified and variable according to the fluid intake. There is a UK audit. No cases of post-contrast acute kidney injury happened before. The protocol, as I was just saying, you can either go for the CC, the position of the two breasts, or one breast and you take the two positions. However, in my own facility, I prefer sandwiching the diseased breast in the middle. Like, for example, if the lady has a lesion in the left breast, I start with the right CC, left MLO, and then I go back to the right MLO. And in that case, I'm just giving time for the contrast to reach the pathological site. One important thing is that we don't start compression, as you can see in the technique I told you, after 2 minutes. We wait 2 minutes without compression so as to give time for the contrast to reach the lesion, because compression starts, it can evade the contrast and we don't see a proper contrast. Lately, in 2022, they added an annex to the BIRADS lexicon with the contrast enhanced mammography terminology and atlas, where we start with the breast composition. The breast composition, we get it from the low energy images, the background parenchymal enhancement, which can be minimal, mild, moderate, or marked, and then we have to comment whether it's symmetric or asymmetric. As you can see here, this is a minimal enhancement, mild enhancement, moderate enhancement. To some extent, it's asymmetric, and this is a marked enhancement that actually obscures proper contrast uptake in masses. The first question we have is there a contrast uptake, yes or no? This is an example of a contrast uptake that is faint in a fibroadenoma, another fibroadenoma that did not enhance at all. The ACR lexicon regarding the mass, we should describe the mass in terms of oval, round, irregular, and we remove the lobular, as I already said. The margin circumscribed or not circumscribed, and the not circumscribed are either irregular or speculated, and we're going towards the malignancy. Internal enhancement, homogeneous, is mostly benign. Heterogeneous and rim enhancement point into malignancy. And I will just give a comment about the rim enhancement, because this is one of the things where the MRI exceeds the contrast enhanced mammography in the accuracy of rim enhancing masses because of the T2 weighted images. The non-mass enhancement is an enhancement that does not have a convex border. It does not have a clear margin between the enhancement and the non-enhancing area. The distribution may be diffuse, multiple regions, regional, focal, linear, and segmental, which are the more suspicious ones. Internal enhancement pattern, homogeneous, which is benign. Heterogeneous and clumped point to a malignancy. And then enhancing asymmetry and the lesion conspicuousy. Something different in the BI-RADS lexicon of the SEM is that we have a lesion in the mammogram in the low energy. So we need, for example, we have a focal asymmetry, but we found a mass in the recombined image. We are somehow obliged to comment on the focal asymmetry. Did it enhance or did it not? And if it enhanced, is it partially enhancing? The extent, is it partially enhancing, completely enhancing, beyond the mammographic lesion, or no enhancement at all? And the lesion conspicuousy, as we just mentioned. The associated features are just like any other modality. We need to comment about the nipple retraction or invasion, skin retraction, thickening, skin invasion, axillary adenopathy. As you may notice that we have not commented about the chest wall. And this is one of the drawbacks of contrast-enhanced mammography. If we have a deep lesion, we don't have the luxury of commenting on the chest wall as we have it in the MRI. So regarding the shape, it may be round, it may be oval, maybe irregular, and we omitted the lobular because 2 or 3 gentle lobulations are taken into the oval shape. The margin can be well circumscribed or not well circumscribed, be it irregular or speculated. Internal enhancement, this is a homogeneous enhancement in a fibroadenoma. It's a pathognomonic feature of the fibroadenoma to have dark internal septations, whether in contrast mammography or in MRI. This is a heterogeneous enhancement in an invasive ductal carcinoma, ring enhancement in a seroma, and ring enhancement in an IDC. And let me tell you that in these 2 cases, MRI would be superior because of 2 sequences in the MRI, the T2 weighted images and the diffusion weighted images. The contrast uptake descriptors. The contrast may be taken as a mass, as we just said. It might be in a focus, and the faint solitary foci are usually adenotic or just fibroglandular tissue, especially if they are multiple bilateral. If you have a solitary, unique, strongly enhancing focus, this needs work up because it might be an invasive, small invasive ductal carcinoma. And in this last case, there is a multiple bilateral intense foci, and these were invasive ductal carcinoma and invasive lobular carcinoma. The non-mass enhancement, the pattern is important. Is it internally? Is it homogeneous, like in the first one, heterogeneous, clumped or clustered ring? And this case is in the literature it is rare, but we find it a lot I find it a lot in my country, in Egypt, and I think in India as well. The idiopathic granulomatous mastitis, it's a very strong, nasty mimicker of breast cancer. The distribution might be just focal, a small focus of non-mass enhancement, linear. It might be segmental, just as the calcification. I always like to compare the non-mass enhancement to the calcifications in mammography. The regional non-mass enhancement in an invasive ductal carcinoma, multiple regions of enhancement, and the diffuse enhancement, which is usually benign, like in here it was an adenosis. What is a malignant uptake? If it's an irregular shape with irregular speculated margin and intense heterogeneous enhancement, if we are talking about a mass. The report organization, just as in any report, we need to start by stating the indication of examination, the technique that we have used compared to priors, succinct description of the overall breast composition, ACR A, B, C, D, and the description of any important findings using the ACR by RADS lexicon descriptors, final assessment, and recommendation forum management. This is an example of a case that I have reported. I started with the clinical history, the procedure. I used comparison to previous studies, and then I start commenting upon the low energy as if I'm commenting on a mammogram using the mammography descriptors, calcification, mass focal asymmetry, etc. And then I comment about the BPE, which is the background parenchymal enhancement. I state if there are no suspicious mass or non-mass enhancement. And in the description of the enhancement, it is very important to put in mind that you are describing something to a referring clinician who wants to go and proceed with a surgery and put a plan for his surgery. You need to describe, is it a mass or non-mass or focus? You need to tell him the size, preferably in three orthogonal planes, the distance from the nipple, and the distance from the overlying skin. We do a complementary ultrasound because the axillary lymph nodes are best evaluated by ultrasound, and it is a weak point in contrast mammography unless they are real pathological lymph nodes. And not only for that, but also because we want to find if we can target the suspicious lesion under ultrasound guidance. As I just said, whenever we can target under ultrasound, this is the best modality to target with. I gave a BI-RADS category for each breast, and then I recommend. It is important in the SEM technique to give a hint for future follow-ups of the case if she had an allergic reaction during injection, because in that case, we might refer her next time to an MRI or just have a preventive corticosteroid treatment before the procedure. And the comparison is very important. Now, let me tell you the indications of contrast-enhanced mammography in terms of a clinical scenario and in terms of a lesion that we have. Meaning that in a clinical scenario of screening, if I have a lady who is in average risk of developing breast cancer, the first thing I would do definitely, and everybody would do, is mammography according to her age. And if we have DBT, that would be great, as I was just explaining in the last session. If we have the idea of having a combo with a synthetic 2D image, then I have reduced the radiation and got less recall rate, especially in dense breast. The disadvantage is a higher radiation dose with the full field digital, with the DBT, unless we have this option. Moderate risk, which means from 15 to 20% lifetime risk of developing breast cancer, I might add handheld ultrasound or automated breast ultrasound or eBBI. And this is beneficial as well in the dense breast. The only problem is that we have high false positive in ultrasound. More than 20% risk of developing breast cancer, these are the high-risk patients where I should introduce the dynamic contrast enhanced MRI to be performed every 6 months, which means I do mammography, and then after 6 months, I do dynamic contrast enhanced MRI. At the end of the day, the lady is doing MRI every year and mammography every year. We can pick up microcalcifications, and we can pick up any enhancing lesion or enhancing high-grade DCIS with no interval left. Contrast-enhanced mammography in screening, yes, it is there, but it has a higher radiation than MRI, of course. And in those ladies with BRCA1 genetic mutation, they are very radiosensitive. So we'd better avoid DBT and contrast-enhanced mammography. Pathological nipple discharge or bleeding the nipple. This is a clinical scenario where dynamic, of course, we start with the full field digital mammography and ultrasound. If you find a papilloma, we biopsy it. But if we cannot, dynamic contrast enhanced mammography, MRI is preferable because of the T2 weighted images where the ducts are filled with water. So it's kind of an imitation to the galactography. We sometimes call it MR ductography. All right, so this is Another clinical scenario, if it's a diagnostic case with a breast lump, we go by the book. We do full field digital mammography or ultrasound if the lady is less than 35-year-old, or we do something very nice that have been that has started in Gustave Roussy Institute in France, which is called the one-stop clinic. The lady, if she is coming with a symptom, she is taken into contrast enhanced mammography. So I take the benefit of two. I take the low energy as a mammogram, and then I take the benefit of an enhancing lesion. And at the same time, they used to, it was, I think it was like a pilot study that took a few years and then they stopped it. But then they do a cytology. So on the same day, the lady has a final say whether she is going into the suspicious loop or not. Thank you very much. Okay, so this is one good thing. If we are doing breast cancer staging, as in we want to know the exact size, we want to check the multiplicity, multifocality, the axillary lymph node, we go for dynamic contrast enhanced MRI or CISM. But mind you that MRI best correlates with the pathological size. In case of inflammatory cases, both are the same, whether dynamic, whether MRI or not. They won't actually add so much unless it's a malignant mass. Problem solving, we have both, but mind you that if we have a suspicious lesion and we can see it with ultrasound, we do not jump into contrast mammography or MRI unless we biopsy the lesion first. So MRI or contrast studies are not a substitute for biopsy. So let's jump into, we're still in the clinical scenarios. Decision, the surgeon needs a decision whether to do a sentinel lymph node biopsy or axillary lymph node dissection. In that case, which one is the best? It is the MRI, of course. And the PET MRI is even now gaining more credit in the axillary lymph node assessment, but it needs more evidence. And what we do is that, like in the case that I showed you before, we clip the lymph node prior to surgery and prior to neoadjuvant chemotherapy. If we're doing post-operative follow-up surveillance, both are the same, but architectural distortion can be cleared by DBT before even reaching the contrast study. And fat necrosis, like I was just saying in the ring-enhancing lesion, fat necrosis is sorted out in the T1 non-fat, non-contrast sequence. Pathological axillary lymph node with no abnormality in the breast, which we sometimes call cancer of unknown primary, dynamic contrast enhanced MRI and CISM are the same, but mind you, we do a biopsy from the pathological lymph node first to make sure that this is not, for example, a lymphoma. We have to make sure that the primary cancer is mammary. And the male breast, we can do either or. So now I chose the modality according to the clinical scenario. Now let's choose the modality according to the lesion. In some lesions that are according to the location, in some location which we call blind zones in a mammography, like in the medial sides of the breast or the deeply located lesions, the MRI is superior. Monitoring response to neoadjuvant chemotherapy, especially triple-negative cancers and HER2 positive, MRI trumps. Monitoring response to neoadjuvant calcification, in that case, of course, contrast mammography is the best. Ring-enhancing lesion, again, because ring-enhancing lesion, triple-negative is one of them, so MRI is better. Axillary nodal basins, so we can get the nodal burden. MRI is best, and especially in the lymph nodes that are in level 2 and 3. Extramammary signs, again, MRI trumps. Which modality now? Relating to the patient. So for the cost, CISM is less expensive. The ability and ease to analyze by the surgeons and the doctors is better with the contrast mammography. Time is better, it is more rapid as in contrast mammography. Patient and clinician preference, the surgeons are usually used to seeing mammograms since old times. So when you give them a mammogram with an enhancement, it's really nice for them, and unlike giving them a T1, T2 and dynamic post-contrast. The contraindication, the guidance for biopsy Unfortunately, it's not present in Egypt, but we have contrast-enhanced mammography biopsy. So if we have the possibility of doing CISM is better, and sometimes even we find the lesion in MRI, and because we cannot localize it and biopsy it, we go and do contrast mammography and biopsy there. As in for the contraindication, overweight, pacemaker, claustrophobia, the contraindications of MRI are the preferable indications for contrast mammography, except pregnancy, lactation, and renal impairment. In both cases, we do PEM. This is an example of a case who is a 52-year-old screening post-conserving breast surgery, and as you can see in the, this is a full-field digital mammography or a synthetic 2D mammography with a retroareolar this star of architectural distortion. In the DBT, it appeared even more conspicuous. So we injected contrast and there was no contrast. And mind you that the negative predictive value of contrast-enhanced mammography is very high. So when we have no contrast uptake, we are almost always sure that this is a benign case, except few exceptions. Screening high-risk patient, this was a young lady, 40-year-old, who had a positive maternal and maternal aunt positive family history of breast cancer. After we did the contrast, we had this non-mass, it was a segmental non-mass clumped non-mass enhancement, as you can see. Nothing was seen in ultrasound, so I took her to a place where we could do contrast-enhanced mammography, and the biopsy came back as fibroadenosis and PASH, which is pseudo-angiomatous stromal hyperplasia. It is a benign condition. Another 70-year-old lady following up after her right conserving breast surgery, and we had this architectural distortion in the operative bed that took enhancement in a nasty way. It is a around speculated mass enhancement, and it turned out to be a recurrence. 44-year-old with a left palpable mass, who had a very dense breast. This was the mass. This is the mass that was seen only in the full-field digital mammography. However, in contrast mammography, there were multiple masses, and this is pathognomonic for fibroadenoma. And it came back as fibrosclerotic tissue core with focal fibroadenomatous hyperplasia. How about contrast study and DCIS? Which comes to answer a question. If we have calcification, would we do contrast-enhanced mammography? The answer personally is yes, because logically speaking, tumor angiogenesis, cancer means angiogenesis, and angiogenesis, which is leaky vessels, mean enhancement. So by default, as you can see here, this is a duct filled with malignant cells, and there is a blood vessel reaching here. So there should be neovascularization here that would leak and end into enhancement. So if no enhancement, there is no biologically relevant cancer. Dynamic contrast-enhanced MRI has a very high negative predictive value in non-calcified lesions. How about calcifications? In those studies, one of them is a review and meta-analysis. They said that a negative supplementary contrast-enhanced MRI could potentially avoid around 81% of unnecessary stereotactic biopsies in BI-RAD for calcification, at a cost of, we will miss 4%. Out of the 4%, 1.6 are invasive cancers, which means that if your MRI is negative, you can probably promise the patient that she won't come back within the next year with an aggressive cancer. This is an example of a contrast study in case of suspected microcalcification. I don't know if you can see the small group of microcalcifications here. This is a magnified image, and this is the extent of non-mass enhancement after contrast enhanced MRI. Here it was that small, and here it is 10 centimeters heterogeneous clumped non-mass enhancement of DCIS. However, if you don't have the chance to do an MRI or a contrast mammography, or they don't enhance, and you have this group, and this was a case that I had, she had this group of pleomorphic calcifications, I will not wait for the contrast to negate, And actually, I went and took a biopsy, and it came back benign. Suspicious calcifications can be visible on ultrasound. So again, whenever you have a suspicious lesion, your first guidance and the first guidance you're looking for pathological verification is ultrasound. So this case came with a central lower segmental distribution of pleomorphic calcifications. It was visible on ultrasound, and to make sure that I took the cores containing calcification, and I mammographically imaged the cores and made sure that they had calcification, and it came back as DCIS, and it had an invasive component. How about the response to neoadjuvant chemotherapy? Compared to contrast-enhanced MRI, contrast mammography has equal specificity, even greater sensitivity, and excellent performance, which may have a brighter prospect in evaluating pathological response of breast cancer to neoadjuvant chemotherapy. Of course, the radiation is an issue, but tell you what, the lady takes already mostly, she is going to go into radiotherapy. So what is this radiation compared to the radiotherapy? This is an example of a 48-year-old female who had a grade 2 invasive ductal carcinoma and 60 millimeter of DCIS. This is pre-neoadjuvant chemotherapy, and this is post-neoadjuvant chemotherapy. There is a marked improvement in the enhancement, and we have the RECIST, which we use to evaluate the percentage of improvement after neoadjuvant chemotherapy. This is a case of a vanishing tumor. Here you can see the mass enhancement, it's no more here, and this is a case of a complete radiological response that showed complete pathological response after surgery. This is a segmental calcification. As you can see, prior to neoadjuvant chemotherapy, still there, it was enhancing as a non-mass enhancement. It's not here. So the contrast mammography here helps in one important thing, that I can do bracketing for the surgeon based on the calcifications that are there. This is not possible by MRI. A 50-year-old lady with right IDC grade 2, and she did contrast mammography for proper staging. She had this round irregular mass with suspected intraductal extension that was confirmed. This is an intramammary lymph node. It was confirmed, the ultrasound picture, it was confirmed after contrast mammography to be an enhancing duct reaching the nipple, which will alter her surgical plan. But then we found in the other breast a very small standing out focus that we took the patient to the ultrasound. This is the index mass, and this is the small satellite that came back as a left 5 millimeter invasive ductal carcinoma. This is a 56-year-old female with right breast coming to check for multiplicity and laterality. Upon doing the contrast mammography, this is the first mass. These are foci just to keep it in the multifocal setting. However, there is a distant small focus that was found in ultrasound and came back as an invasive lobular carcinoma. An example of a CUP syndrome, which is a cancer of unknown origin. This young lady came with this dense breast and thickened skin, increased trabeculations, and suspected pathological lymph nodes. They were biopsied and came back adenocarcinoma of mammary origin. Contrast mammography was done, and it revealed this extensive regional non-mass clump, non-mass enhancement. We went back again. At the beginning, we couldn't see anything in the ultrasound, but guided by the contrast enhanced mammography, we actually tried to reach this area. We went to the upper outer quadrant and found an area that we call now, lately, we call it non-mass finding, which is altered echogenicity or architectural distortion, biopsied it, and it came back malignant. How about the pathological nipple discharge or bleeding per nipple? As I was just saying, the MRI is superior to contrast mammography. This is an example of a linear or rather segmental clump non-mass enhancement of DCIS. Another case with an oval, well-circumscribed, homogeneously enhancing mass papilloma. This is the famous tram track enhancement of duct ectasia or periductal mastitis, and another case showing multiple papillomata. 66-year-old nipple changes. The lady came complaining of nipple changes, itching, and a crust that actually it took her a while because she used to go to a dermatologist to put emollients and moisturizers. And then when she came for, that was a 2-in-1 actually. We did the contrast enhanced mammogram. We used the low energy. Do you see anything in this mammogram? Anyone sees anything? Don't tell me that I missed something. Well, okay. She took the contrast material, and as you can see, I could see those foci of enhancement. And here the clinical situation or the clinical context is important, because from the clinical view of the patient, Paget disease was already suspected, and we were looking for the extent, or if it was a negative, we were going to do a punch biopsy from the nipple and areola. So this lady, I took a biopsy from this. It was like an architectural distortion, retroareolar. I took a biopsy, and I even took a biopsy from the areolar skin. You know, I take the needle, and I prefer in that case a semi-automatic needle, and then I turn it within the skin, within the thickened skin. And the areolar skin is usually thickened. It's just a bit painful. And I take course from the skin, and it came back as infiltrating duct carcinoma. The lady did not, she opted for a complete skin sparing mastectomy. The nipple and areola were removed, and she put a silicone implant, and we kept following her up until a few days ago. During her ultrasound follow-up, I found this lesion at 12 o'clock in the right breast. I took a biopsy because I wanted to save time, and then I did the contrast mammography, and it came back as this small enhancing mass and some non-mass enhancement reaching up around 1 centimeter from the nipple. I'm not sure what the decision of the, no, well, actually, he is thinking of a conserving breast surgery, and he asked me to put a clip in the mass because I think that she's gonna take neoadjuvant therapy. But when I go back, I'll see what happens. Follow-up of the treated breast. So this is a case where she had a left mastectomy, and upon her follow-up, as you can see, there is plump non-mass enhancement that is seen similarly in the MRI, which is a recurrence. Another case, treated breast, 56-year-old female with a right breast conservation surgery, and she has this small architectural distortion, retroareolar, which is what we usually do, but it is really comforting to see this architectural distortion not enhancing, especially if I don't have priors to confirm the stability. Okay. So, I'm getting near the end of the lecture, and I am a person who likes algorithms. So I put an algorithm for the contrast enhanced mammography. When you do a contrast enhanced mammography, you have either enhancement, you have already a suspicious mass. You have enhancement of this suspicious mass, so you go and look for the mass by ultrasound. If you can find it, please put a needle inside. If not, then you take a stereotactic biopsy based on the low energy, or contrast enhanced mammography biopsy. If there is no enhancement, well, that's good news. If there is no enhancement, that is benign, so you do no biopsy, you do nothing. But if there is a new enhancing area, whether in the eBBI or contralateral breast, we try to find the correlate in the low energy, so as to be able to target it stereotactically or do a targeted ultrasound. If it is suspicious, then please go and do ultrasound or stereo biopsy from the index mass, from the new mass. If no correlate by low energy or ultrasound, this is the problem. If you have an MRI, if you have a contrast enhanced mammography guided biopsy, then you do a biopsy. If you don't have and you have an MRI guided biopsy, then you do an MRI and use it as a guidance for biopsy. If both are not there, you will have to follow up after 6 months by contrast enhanced mammogram. We have a lot of data, we have a lot of surveys and literature upon the indications of each and every modality. So my take-home message is that the radiologist is a main pillar in the multidisciplinary team. He is responsible, or she is responsible, for choosing the best modality, tailored for the patient, and to answer the clinical question requested by the clinician. The advances in breast imaging are vast and they are fast. So my take-home message is that the clinician, the pathologist, and the radiologist need to work hand in hand according to the international guidelines, tailoring them, preferably tailoring them to the local institutional resources and disease epidemiology in the country itself. Thank you very much. لا فاكرة. كلامي لها كتير. I know you're all, you must be all very tired. That's great. Great to hear. Okay, so let's start with our fourth. Okay. So we're going to shed some highlights on the breast MRI. The radiologist, as we mentioned before, plays a crucial role in the multidisciplinary management of breast cancer patients. She or he is responsible for the detection, proper diagnosis, and accurate extent and localization of the lesions. Dynamic contrast enhanced MRI of the breast has the highest sensitivity for breast cancer detection among clinical imaging modalities because it combines morphological and functional techniques, and in the morphological setting, it is a multi-planar modality. The indications of dynamic contrast enhanced MRI goes from screening to diagnosis. And the indications in the diagnostic setting, if we leave the high-risk screening, is localized or focally localized into preoperative staging, evaluation of neoadjuvant chemotherapy, the response, monitoring the neoadjuvant chemotherapy response, and the high-risk screening as a third one. It has other indications, like in augmentation or reconstruction. It might be there for suspected implant rupture, because I'm just focusing on this point because some people ask for non-contrast enhanced MRI. If the issue is solely to detect rupture, well, okay, we can do that. But if we are looking, just screening a patient, every patient starting 40 years needs to be screened. So if the idea is about screening, so we have to inject contrast. Occult primary breast cancer, which is TOP syndrome, cancer of unknown origin, when we have an axillary lymph node biopsied and returned as adenocarcinoma of mammary origin, we need to have a highly sensitive method to depict and detect a cancer, a small cancer, and otherwise masked cancer in the other modalities. Suspected local recurrence in the post-operative setting, equivocal findings at mammo and ultrasound, and this one has to be cautiously addressed, because we do that only if we cannot do a biopsy. If we have a suspicious lesion that is seen by ultrasound or stereo, we take a biopsy. Nipple discharge, as I showed you in the contrast mammo, where I showed you the MRI is superior to contrast mammography in the nipple discharge, especially if bleeding per nipple. Inflammatory breast cancer, male breast, are indications for contrast-enhanced dynamic contrast-enhanced MRI. The principle is to evaluate the permeability of blood vessels by injecting IV gadolinium chelate that shortens the local T1 time, leading to higher signal on T1 weighted image. So neoangiogenesis leads to formation of weak leaky vessels, faster extravasation of contrast agents, and rapid local enhancement and rapid washout. What is multi-parametric MRI? Multi-parametric MRI is where you combine the morphology with functional data. And the morphology is seen by the MRI descriptors that we take from the BI-RADS lexicon, and the function is through the kinetic curve analysis, the diffusion, DWI and ADC maps, and the spectroscopy, which is the MR spectroscopy. So the MRI technique that we are going to discuss, but first, we have to take proper clinical history compared to priors. In the clinical history, it is our goal in dynamic contrast enhanced MRI is to answer a clinical question. We have a breast lump, a nipple discharge, or other patient symptoms. So we have to be targeted to answer these questions. It's important to know the phase of menstrual cycle, whether the patient is taking hormone replacement therapy, anti-hormonal therapy, and radiation therapy. The risk factors for breast cancer, including family history, should be listed for high-risk screening. And a history of biopsy or surgery, the biopsy date, and the pathology results have to be documented. MRI, ultrasound, and mammography, particularly if a finding, here is when I address the comparison to other priors, whether it is an old MRI, ultrasound, mammography, particularly if the finding we are analyzing was, or the finding that dictated the MRI was prompted, it is the one that prompted MRI study. Breast MRI should be interpreted by a breast imaging radiologist, because we are going to look at the prior mammographic and ultrasound images, and we might need to go and do a second look ultrasound to detect the lesion that we have found. And the review of the prior images also need to be done by the technologist, because it gives him an impression of what the proper positioning. The lady has large breasts, she needs pads to be put, and imaging challenges that may be in each patient before the patient enters the imaging unit. So for the technique, we need to talk about the machine requirements, the technical considerations in the imaging protocol. As for the requirements from the machine, it's best to use a field strength of at least 1.5. We can go up to 7 Tesla, but we don't go below 1.5 Tesla, preferably in a closed machine, to acquire images at a sufficiently high spatial resolution. In MRI, we are playing with 2 factors, the spatial resolution and the temporal resolution. So a field that is 1.5 and more provides or secures a good spatial resolution. Preferably dedicated bilateral breast coils, favorably multi-channel, compatible with parallel imaging, with routine regular checkups. High spatial resolution with a 60 to 90 seconds acquisition time per dynamic phase are antagonist requirements. So parallel imaging provides the gain in acquisition time that is needed. Technical consideration, we need to have contrast medium, gadolinium DTPA, The contrast dose is 0.1 millimole per kilogram. The patient needs to be weighted before the study. The injection time is very small. It takes less than 10 seconds. We inject saline after the contrast in order to wash out the line. And the maximum contrast between the cancer and adjacent fibroglandular tissue is around 1 to 2 minutes, from 60 to 90 seconds post-GAD. Slice thickness, preferably less than 3 millimeter. Acquisition time, as we said, 60 to 90 seconds, less than 2 minutes. We repeat until 6 minutes. The voxel size is less than 2.5 in any direction. We are aiming at finding cancers of 5 millimeters, so the thickness and the voxel size are important to be small. The acquisition plane, bilateral axial, and I will have an overview of the different planes. The phase encoding left to right, axial, so as to avoid the heart aliasing. As for the timing, in premenopausal women during the second week, from 6 to 16, we can just schedule it just after the menses has stopped. The glandular tissue enhances more in the secretory phase, second half of the cycle. Thereby, it has increased BPE and more false positives. Unless urgent, in postmenopausal women on HRT, it should be discontinued at least 4 weeks prior to scanning. If the patient underwent surgery or radiotherapy, it's preferable to wait until 6 to 9 months. Enhancement can be seen up to 18 months. In few cases, after 18 months, there should be no enhancement owing to radiotherapy treatment. However, sometimes we have cases coming for MRI, checking for residual after 1 month of surgery, and after 1 month, we can and we are able to discriminate granulation tissue or enhancement due to inflammation or residual. Prior to the procedure, the patient management, we need to talk to the patient, and we need to instruct our nurses that they need to have a conversation with the patient while positioning the patient in the magnet to reduce her anxiety and thereby reduce motion artifacts. And we need to inform the patient that at some point there will be a contrast going in and that she will feel something cold in her arm. And one of the important tips is that we don't talk to the patient while she is in the magnet. Some people, they get the patient into the magnet, she's positioned, and as soon as the contrast is going to start, the technologist starts speaking to the patient. Now you're going to feel something cold flowing in your arm. So the patient just moves to say, what are you saying? And now we have a motion artifact. So proper positioning is important. They lie in the prone position with the breast hanging within the recesses of the coil, allowing the breast tissue to spread freely, detecting abnormalities, preventing motion artifacts, without excessive compression so as not to decrease the contrast enhancement, head first and arms padding. Contrast material should be administered as at the dose that we have mentioned. Power injector is preferable at a rate of 2 milliliters per second. The contrast material should be flushed with saline. Proper positioning should allow free positioning of the breast, because any compression of the breast or over pressure from one side can lead to motion artifact and can lead to artifact from poor fat saturation, like in this case where the superior lying coil in the sagittal post-contrast MRI showing artifact from poor fat suppression. Another artifact, like in here, these are large breasts and there is inhomogeneous fat suppression, bilateral compression, and as you can see, there is medial artifact, and in this case, there is what we call anterior puddling because the breast is large, it's not positioned freely in the coil. Another case of artifacts where there is poor fat suppression laterally. Here there are skin folds because the breast is larger than the coil. So we have tips and tricks and tools to use, like fat saturation pad, sponges, to roll a blanket and put it, or a towel. Pre-contrast sequences. So we are going to start now with the sequence before we inject the contrast. One important sequence is the native T1, and the native T1 is an axial T1 that is non-fat suppressed and non-contrast. Why do we use this? Why is it important to have this one? Because this is the mask that after 60 or 90 seconds after contrast, we are going to subtract the without contrast from we will take the contrast one and subtract the without contrast to have a subtracted image. And I'm going to show you in a while. And after surgery and trauma, the fat and the blood are hyper-intense in T1, non-fat, non-contrast enhanced. So we can depict a hematoma, a fat necrosis, or just confirm that this is an intramammary lymph node. Axial T2 weighted images, non-fat suppressed. This is what we call the money image. It's a problem solver in MRI, especially in the triple negative cases and the ring enhancing lesions. And this is one sequence that makes the MRI sometimes superior to the contrast enhanced mammography. The pre-contrast images or sequences again is the stare, and some people prefer to do a sagittal T2 weighted image so that they have axial T2 weighted image, which is similar to the craniocaudal in mammography, and a sagittal T2 weighted image that is similar to the MLO. The acquisition plans, we take axial, we usually take axial, this is a must. We might take coronal and we take sagittal, and each one has advantages. Like the axial has a better temporal solution, resolution. The coronal is very nice in the temporal resolution and in the localization of the lesion. Sagittal is very nice in the ductal enhancement and the spatial resolution and the fat suppression. In the pre-contrast sequences as well, we have the diffusion weighted image. It's preferable to perform the diffusion weighted before contrast material administration. And then in the T1 non-fat, non-contrast and fat necrosis, this is an example of a large mass with fat necrosis. As you can see, it has ring enhancement, and we could confirm that this is fat necrosis because of the pre-contrast fat, non-saturated T1. Let's start to see the post-contrast sequences. Is a first one taken at 60 to 90 seconds post-injection. We can take as well sagittal, but these are reconstructed. This is a native T1 non-fat saturated. As you can see, this one is taken at 12:54. And then this one is at 1:19 p.m. and this is 1:20 p.m. So it's like 1 minute difference. This is the mass, the rounded mass, and it's starting to enhance. But the conspicuity in T1 weighted non-fat saturation with contrast is not good. So we have one of two options, either to do fat saturation or to do subtraction or to do both. I personally prefer the subtraction. And when we subtract the post-contrast from the non-contrast enhanced, we find the subtracted image and the ring enhancing mass. Is that clear? Is it clear? Okay. So this is an example of post-contrast sequences, dynamic T1 weighted images before, and 5 to 6 consecutive repetitions after gadolinium injection. Each one has a difference like 60 seconds in between. This is the non-enhancing lesion in the pre-contrast, and then we injected the contrast. As you can see, it is filling out until it becomes as white as the surrounding fat. So it's either I do suppression for this fat, it becomes black, so I can see here the mass enhancing properly, or I do a subtraction. I remove this one from all these ones, and I come back with a subtracted image. And this is how it is strongly enhancing against a subtracted background. Post-contrast acquisition plans or reconstructed plans, I personally prefer having a coronal image because it helps me with the clock. Here, I would go for the distance from the nipple, and then I say it's just retroareolar, and I try to see it in the sagittal to detect whether it's 12 o'clock or not. But in the coronal, it's just evident in the clock position. How do we read MRI? Where do we start? What is the hanging protocol that we use? We start first aiming at detecting the lesion. And to detect the lesion, we find it in the first, either in the first subtracted or in the MIP images, which is the volume rendered maximum intensity projection image. And then I start differentiating, characterizing. Characterizing happens in the other phases. So this is an example of a hanging protocol. The first one here is the MIP image, and there is a lesion detected here. So I start looking at the curve or the enhancement of the lesion over time visually. And I look at this one, and this is a delayed one. This is 121, and this is 124. So there is 3 minutes difference between the two, and I already can depict some washout in the lesion. After that, I go back to the T2 weighted image, because a hypo-intense lesion in the T2 weighted image tends towards malignancy. After that, I go and check the diffusion, and the lesion is restricted in diffusion. It is bright, it is light bulb bright, and it is low in the ADC map. I pick up the ADC value, and below 1.2 as a threshold is hinting towards malignancy. Sagittal and coronal helps in the craniocaudal measurement and the localization of the lesion for MR-directed ultrasound, second look ultrasound. So first of all, I am looking for detecting something. If there is no enhancement, that's good news. It's probably a benign lesion. If in the MIP, like in that case, I find an enhancement, so I have to go and analyze it. This enhancement is seen here as a ring enhancement in the first subtracted image. The diffusion, we have the enhancing lesion in the contrast subtracted images. I put a hair cross to find the lesion in the diffusion. It is restricted and low ADC. What are the lesion types? What are the enhancement types? Either mass or non-mass or focus. And the differential diagnosis between mass and non-mass are the following. A mass could be an invasive breast cancer, could be benign like a fibroadenoma, phylloides, hamartoma, fat necrosis, or scar if it's enhancing. And the non-mass is either DCIS or invasive lobular carcinoma in the malignant setting. Adenosis versus fibrocystic changes and PASH in the non-malignant setting. What are the diagnosing criteria? The enhancement morphology and the enhancement kinetics and the tissue signal intensity pre-contrast in the T2 weighted images and the diffusion restriction. The lesion type, the mass has a correlate in T1 weighted image. This means it's a mass. So I start looking at the shape and the margin, or a non-mass lesion, or a focus, and we here in the non-mass we look at the distribution internally, internal enhancement, distribution, and enhancement symmetry. So enhancing lesions are morphologically described as mass, focus, and non-mass. This is a focus, which is an enhancement less than 5 millimeters. It is too small to be characterized morphologically and has no corresponding finding in the pre-contrast images. A focus is either malignant if it's unique, distinct from the BPE, no fatty hilum, with washout kinetics, like this one, which is a small breast cancer, or benign, which is not unique compared to the BPE, might be bright on bright fluid imaging as the stare, possibly fatty hilum, persistent kinetics, and stable when compared to the prior examination or seen on a baseline examination. So these are multiple foci of BPE. There is a nice treat for beginners and even later on, which is called the Kaiser score, where they look at the enhancing lesion and see if there is a root sign like a specule. If the root sign is absent, we look at the delayed phase. If it's persistent, as in kinetics, like a time intensity curve 1, we look at the margins. If it's irregular, it's score 3. And we continue as is, and we calculate the score. A lesion less than 5, we do no biopsy. A lesion more than 5, we do biopsy. T2-weighted images, as I has mentioned, why do we take it? Because the signal intensity in T2 hints towards benignity or else. Benign, if it's high signal, it's benign, unless it's a mucinous carcinoma or a necrotic cancer, metaplastic triple negative breast cancer, they have high signal on T2-weighted image. Low signal intensity in T2, this is cancer. And the third thing that is very peculiar to T2 and STAIR is a perifocal or prepectoral edema, because these have a poor prognostic sign in patients with known breast cancer. How to write a structured report? Clinical history and indication, again, comparison with priors, the sequences and post-processing, composition and BPE, morphologic and kinetic features of findings, final assessment, a BIRAT score, and BIRAT 3 and 0 are not preferable in MRI. And further recommendations. The amount of fibroglandular tissue goes from almost entirely fatty, scattered fibroglandular tissue, heterogeneous fibroglandular, and extreme fibroglandular. The BPE, which is the background parenchymal enhancement, can be minimal, mild, moderate, and marked. And mind you that the fibroglandular tissue is not related to the background parenchymal enhancement, like in this case, where there is extreme fibroglandular tissue and mild BPE. Is it symmetric or asymmetric? So in summary, the important points is the native that we look at is the native T1. And in the native T1, we comment on the fibroglandular tissue. And then we have the post-contrast. We have the post-contrast, the first one, where we comment on the background parenchymal enhancement, and we detect the lesion type, whether there is enhancement or no. And if there is enhancement, is it a mass? So we look at the shape, margin, and internal enhancement. Is it non-mass? We look at the distribution and internal enhancement pattern. And then we shift to the dynamic. In the dynamic, there is a signal intensity versus time curve. And we look whether in the first initial part, is the relative enhancement at 90 seconds less than 50, 50 to 100, or fast more than 100? And the delayed phase, is it persistent or plateau or washout, which is a malignant type curve? The T2, the signal intensity, if it's high, it's benign. If it's low, it's malignant. If there is edema, perifocal, prepectoral, unilateral, bilateral, or diffuse. The diffusion level, whether it's restricted or not, and the ADC value, and we have a cutoff value of 1.2, which we use to cut off between benign and malignant lesions. Diffusion-weighted images, they quantify the random movement of water molecules in tissue, which is influenced by tissue microstructure and cell density. So cancers, they show decreased water diffusion because of cellular packing, leading to higher signal intensity and lower ADC value. Let's discuss the shape of the enhancing masses. It can be oval, including lobulated, can be round, or can be irregular. The margin can be well circumscribed or not well circumscribed, be it speculated, irregular. Internal enhancement characteristics of a mass can show in internal homogeneous enhancement, heterogeneous enhancement, ring enhancement, and dark internal septations, which is pathognomonic for fibroadenoma. The shape, margin, and internal enhancement, irregular, speculated, heterogeneously enhancing, they point at invasive carcinomas. Let's have a look at the non-mass enhancement. The distribution can be focal, regional, linear, or multiple regions, diffuse or segmental as distribution. Internal enhancement can be homogeneous, can be clumped, can be heterogeneous, or multiple clustered rings. How about the dynamic evaluation with time signal intensity curves? The quantitative contrast enhancement is measured in the first part of the curve, and more than 70% at 2 minutes points at malignancy. And then the enhancement curve shape characterization, which is divided into type 1, where there is slow or medium first initial phase, and then progressive filling of the lesion. Type 2, which is a plateau and is divided into type 2A and 2B. And we consider the difference here to be more than 10%, to move from one curve to the other. Or type 3, which is the washout curve, where the gadolinium leaks from the cancer and causes a washout curve and decrease in the signal intensity of enhancement. So as you can see, more than 10% increase is a type 1, plus or minus 10% is a plateau, and more than 10% decrease is a type 3, which is a malignant curve. The structured report is a report where you tick on each and every one. I'll just give a quick example. I will not read all this. Like the amount of fibroglandular tissue, you have choices, and you just tick the one you find, and you then comment on the background parenchymal enhancement. It's very useful in the beginning of reading of MRI when you have a fixed hanging protocol and you have a structured report. So you're quite sure that you're not going to miss any of the criteria you need to address. Other findings can be looking at the nodal basins, axillary, internal mammary, the chest wall to see if there is an invasion or not, and the pre-contrast ductal T1 weighted image high signal, which occurs in periductal mastitis. In the preoperative staging, each and every society has their own recommendations where and when to do the MRI. I will talk about my own practice because this depends on our national guidelines. We do MRI, or we do dynamic contrast enhanced MRI in ACR C and D, in invasive lobular carcinoma because it tends to be bilateral, in DCIS, and to see the relation to the nipple. And in any case where the findings are going to impact the planned surgical procedure, it should be confirmed at pathological examination prior to treatment, which means we are not allowed to alter the surgical procedure until we have a pathological confirmation that the suspicious finding we have in MRI is actually malignant. Preoperative staging, as in unifocal, multifocal, multicentric, and bilateral. This is an example of focal asymmetry. In her left upper breast, spot compression show persistent indistinct margins. It was seen by ultrasound and revealed grade 2 IDC with DCIS. And mind you, this is the extent of the tumor in MRI. Monitoring neoadjuvant chemo response, as in this case, where there is complete radiological response. Another example where the response is partial. The other indication, main indication setting of breast MRI is screening. The American Cancer Society and the American College of Radiology categorize women with a lifetime risk of more than 20% as high risk. And they recommend annual screening with MRI and mammography in this subset of women, as I just told you, every 6 months, alternating. How do we get to know that this patient or that patient has a more than 20% lifetime risk of developing cancer? By the risk assessment questionnaires. And the most famous one is the Tyrer, eBBI's Tyrer-Cuzick eBBI's evaluation because it puts in consideration the breast density. The intermediate risk women, the ACR, now recommends annual breast MRI for women with dense breast and a previous breast cancer diagnosis at an age younger than 50 years. The abbreviated MRI is one that avoids the high cost and limited availability in MRI as the main factors that precludes the widespread use of screening MRI. So the abbreviated one with shorter image acquisition and interpretation time may increase the availability of breast MRI and reduce the cost. I like to look at the MRI as a puzzle, where we combine the morphological data and the kinetic data and the functional data. And we put each and every one, and the most suspicious criteria trumps. So if I have benign criteria, I have type 1 curve, and I don't have diffusion restriction, but I have a speculated mass that is strongly enhancing in the T1 and T2 and dynamic MRI, I would call this one suspicious. And if I have a focus that I cannot comment on the morphology, but it is diffusion, it's seen in diffusion restriction with a type 3 curve, this one is a suspicious finding. Thank you very much. So it's now time for the interactive session. We will stop the video. Okay. Okay.
دكتور.
ميرسي لحضرتك.
دكتور نسرين أحمد.
طبعا معلش انا مش معايا دلوقتي بزنس كاردز. اكيد هنا في
I will just give it to him. No problem. شكرا دكتور نسرين. دكتور سامح علي. منى رضا. مدام منى رضا.
انت محتاجه، انت لازم تاخدي certificate
Thank you
بصراحه
so much
for all your efforts.
Thank you so much دكتور.
You're welcome.
Thank you so much and wish to see you again in our upcoming courses إن شاء الله.
ان شاء الله.
Thank you.
سلامي سلمى كتير. ان شاء الله نشوفكم على خير. ميرسي جدا تعبناكي معانا. Thank you so much. طولت عليكم.
لا بالعكس تماما.